Hi, I'm Dr. Aviva Zohar, and I am an addiction physician. I'm board certified in addiction medicine, family medicine, and preventive medicine. And I've been working in the substance use disorder field for 17 years. I started off in primary care and got introduced to addiction medicine while I was a resident and took to it running. I've been working in outpatient for the last 8 or 9 years, doing outpatient detox. I do medication assisted treatment. I do medication management for depression and anxiety and ketamine assisted psychotherapy. So we're going to talk about ketamine's discovery and history. We're going to talk about a description of ketamine and its mechanism of action. We'll touch on reimbursement, evidence in substance use disorder, applications, as well as protocols. So ketamine's discovery and history is pretty interesting. It starts back in the 1950s. They were looking for a new anesthetic medication with analgesic properties, and PCP, or phencyclidine, was synthesized in 1952 and sold until 1967. It was an injectable anesthetic in the United States. It was safe, it was reliable, but people came out with side effects such as dysphoria, confusion, delirium, and psychosis. It also had well-known abuse potential. It was due to negative psychological effects that it was withdrawn from the market. In 1960s, ketamine was synthesized by Calvin Stevens, working as a consultant for Park Davis Labs, and human trials with prison volunteers in 1964 were started. Ketamine was found to be less addictive, had less adverse side effects, and no emergent delirium like PCP. It also had minimal respiratory depression. The participants at that time described themselves as floating in outer space, no feelings in their limbs. Some of them described feelings of dying, being detached from their physical self. And following this initial research, ketamine was characterized as a dissociative anesthetic. Jumping to the 1970s, it was approved as an anesthesia for children, adults, and the elderly, and they started clinical trials with infusions. The main side effect at the time was hallucination, which was undesirable for clinical practice. The FDA approved ketamine as a field anesthetic in the Vietnam War, and soldiers carried it with them. The term K-hole you might have heard of was coined at that time for ketamine and soldiers that would put themselves in such high dose ketamine to allow themselves to go seek medical care and self-administer the ketamine themselves. It was quick and it worked well in battle. Jumping to the 1980s, increased illicit ketamine use started. Special K was what it was called at the time. Nixon's war on drugs started, and it was still used in the OR and the ER as a medical anesthetic. At that point, it was also confirmed as an NMDAR receptor antagonist. In the 1990s, discovery of other anesthetics such as propofol and this perceived abuse potential and the psychedelic characteristics of ketamine were monumental in classifying it as a class 3 substance. It still had a really good safety profile, short half-life, and it's still one of the most popular agents for procedural anesthesia. Jumping to 2000s, first double-blind placebo-controlled studies. Treatment-resistant depression was the most widely studied, but ketamine was also used for anxiety, PTSD, nerve pain, end of life, and substance use disorder. In March of 2019, it was the first FDA and EU approved S-ketamine nasal spray for treatment-resistant depression. Let's talk about its description and mechanism of action. Again, it's an analog of phencyclidine. Its mechanism of action is it creates neuroplastic changes. It increases protein synthesis. And as an NMDA and glutamate receptor antagonist, it contributes to sedation, decreased sensory input. A partial agonist at the mu-opiate receptor contributes to its sedation and analgesia. Ketamine comes from two places. One is Spravato, that's only S-ketamine, nasal formulation, and then from compounding pharmacy. And that would be the S, which is one enantiomer of it, and the R-ketamine, and that's a racemic mixture. It can be obtained for IV, intramuscular, sublingual. You can have it formulated in topical, even suppositories, although most people don't do it like that. So So reimbursement, we'll talk a little bit about this. So Spravato has guidance for billing on spravato.com. The medication and the treatment may be covered through insurance. The barriers to using Spravato is this REMS program, which is Risk Evaluation Mitigation Strategy. It's a restricted program where the provider has to be certified, the pharmacy has to be certified, and the client themselves has to be enrolled. And there's a fairly lengthy step through insurance process. In comparison, getting ketamine through a compounding pharmacy, you have a lot of dosing options. It is out of network, and the cost to patient is the compounding medication itself, and then the provider's rate. Evidence for substance use disorder, I'm just going to touch on a couple of these. So efficacy of ketamine and substance use disorder by Jones et al. Was a systematic review. They had 7 studies that they identified, 2 for cocaine use disorder, 2 for alcohol use disorder, and 3 for opiate use disorder. And what they found was for both cocaine studies, improvement in cravings, motivation, and decreased cocaine use rates with ketamine. Studies of alcohol use disorder and the opiate use disorder did find improvement in abstinence rates in the ketamine group, with significant effects noted for up to 2 years following a single infusion. Winkett et al. Did a retrospective 2-year chart review with 18 patients with substance use disorder and at least 1 ketamine-assisted psychotherapy session. Their endpoints and outcomes were following the GAD-7 and PHQ-9 for anxiety and depression with problematic substance use disorder. And their results did show statistical significant improvements in anxiety and depression after at least 1 ketamine session. And then ketamine for alcohol use disorder, Kelson et al. Was a systematic review. They had 11 studies they reviewed with an N of 854, and their endpoints synthesized the current evidence for ketamine treatment for alcohol use disorder and its efficacy. The results were mixed with respect to relapse, craving, and withdrawal, but they did find favorable results for people receiving a combination of ketamine and psychotherapy treatment. I want to talk a little bit about ketamine and the medical model versus the ketamine-assisted psychedelic model. Again, it came from anesthesia. So the medical model is IV mode. Here, ketamine offers neuroplastic changes. It's alleviating depression and anxiety and other mental health symptoms. There's flexible dosing with the IV model. You can turn it off if someone's having a challenging experience, turn it back on. Most infusions are about 40 minutes. The setting is a medical facility. You have medical staff observing and monitoring. Whereas the ketamine-assisted psychotherapy model, this is generally the IM, sublingual, and nasal mode. Ketamine here is a transformational agent. It's a longer term. It's used in active psychotherapy process, and there's much more flexible dosing. Usually 45 to 90 minutes for a journey, and total sessions 3 hours. The setting here can be varied. You can do it in office with the provider. You can do it at home via telehealth, or at home where the client does the journey themselves. My experience is the valuable insights, the opportunities are really missed if they're doing this at the home setting. But the other side of it is there's no one size fits all model. You know, you do have greater access to care, and sometimes it's hard for people to get into an office. Sometimes it's hard for people to have access to providers in person. So being flexible with these options can be helpful. I think most people in recovery, active use with substance use disorder should have these primarily in the office. Another thing to note is the IV model doesn't mean they can't do ketamine-assisted psychotherapy. It's just not as accepted. Let's talk about protocols. These are incredibly varied. Spravato has a very well laid out protocol. Induction is 28 milligram per nasal spray. They start with 2 sprays, 1 per nostril, 56 milligrams, and then they can do 56 or 64. It's intranasal twice a week for 4 weeks. Their maintenance is then weeks 5 through 8, once a week, and then after 8 weeks on, it's every 1 to 2 weeks based on response. Their REMS does include every 2 hours monitoring, blood pressure, and checking pulse ox. The IV protocol is generally a dose of 0.5 to 1 milligrams per kilogram. The frequency is generally accepted as twice a week for the first 4 weeks. Same thing, weeks 5 through 12 is weekly, and then adjusting the dosing and the frequency based on response. Most IV protocols have monitoring every 2 hours, including blood pressure and pulse ox. Intramuscular and sublingual protocol, a little bit different. My recommendation is always check blood pressure at start. For the sublingual, you want to start at 150 milligrams sublingual. The IM dose will be the same like the IV, which is 0.5 to 0.1 milligrams per kilograms. And then you can have some flexibility. What we do is we always start with a sublingual dose, and then we can go up from there. We also sometimes will offer a booster of intramuscular in the beginning part of the journey. It allows for a easier launching, if you will, and then a longer journey for people. And then we do have some people that will just have intramuscular. The studies that have been done have very varied protocols, and it's my belief that they should be more based on the comfort of the and education of the provider and what kind of treatment center you're in. And that was lesson 1, ketamine overview.